Thank you, Dr. Walid. Our next speaker is Dr. Jamal Aljubeh, who's a consultant pediatric endocrinologist at Sheikh Khalifa Medical City in Abu Dhabi. His presentation will be a virtual presentation. Unfortunately, he couldn't attend. And his title of the presentation is Challenges of Obesity in Children.
Again, and I'm very happy to be with you, and hopefully next time we'll be with you physically in the conference. I would like again to thank Dr. Wa'am and the organizing and scientific committee for inviting me. So this talk is going to be about childhood obesity. So childhood obesity is rising, so we'll cover the epidemiology briefly, as well as the definition and diagnosis, why we get obese, common pathophysiology, health consequences of childhood obesity, investigations and screening, and some management strategies. So the World Health Organization is monitoring and producing data around the world for obesity in children and adults. They released this report in 2019. At that time, 150 million children were affected with obesity worldwide, and the projection is for this number to reach 250 million children by 2030 if the pattern continues. When we look at the highest obesity rates among children in 2017, showing here the top highest countries in the world, we can see that 4 of the GCC countries are represented here. Kuwait and Qatar have the highest in the Arab region, with an obesity prevalence of about 25%, followed by United Arab Emirates and Bahrain at a prevalence of about 23%. When we look at overweight and obesity, overweight is shown here in gray color and obesity in the dark blue color. In the Middle Eastern region, we noticed that, again, Kuwait has the highest rate of combined overweight and obesity, with a total rate of almost 50%, followed by Qatar, then followed by Bahrain and UAE, with a combined overweight and obesity of about 40%. When we look at Bahrain and United Arab Emirates, we see that the numbers are actually very similar. The combination of overweight and obesity in total is about 40%, and this is even in the younger age group of children between 5 to 9 years of age. So the diagnosis of obesity has been confused by many different definitions for obesity. So in the CDC, the definition is above 85 percentile BMI will be overweight. Obesity is above the 95th percentile BMI for the age and gender. And extreme obesity is more than 120% above the 95th percentile. For children under 2 years of age, it's 97.7 percentile, which is +2 standard deviations above the mean for weight for length. When we look at the WHO, the definition is a little bit different. For children under 5 years of age, overweight is between standard deviation BMI between standard deviation of 2 and 3, whereas obesity is more than 3 standard deviations. And in children above 5 years of age, overweight is between 1 and 2 standard deviations, and obesity is more than 2 standard deviations. In the International Obesity Task Force, they are using the projection of current BMI where it will reach as an adult. So for those with a projection of BMI that will be more than 25 they will be considered overweight, similar to the adults, and over 30 obese. In the Royal College, they consider the 91st percentile overweight and 98th percentile obese. So this has actually created a lot of confusion, and sometimes when we look at research, it's always important to know the methodology and the definition of obesity used, because some of the differences can be due to different methodologies. Why are we obese? So there is environmental changes, as we know, which has led to this remarkable increase in obesity rates over the past 2 to 3 decades, as well as genetic components which have not changed. So in our lifestyle, some of the changes include things like ultra processed food, which is high in sugar and salt, as well as fat. There is the ultra portions, and the vast increase in the size of the meals that we eat, whether it is fast food or regular food, always looking for larger size and special offers. Advertisement that look healthy, and this is actually very deceiving. So a lot of foods that are unhealthy, when they are sold, you can see on the box on the outside the picture of an athlete. So it makes you feel like if you eat this food, you will become very healthy and very athletic, where it's only just the picture on the box. It has nothing to do with the content. The food is now brought to the door with so many delivery options. The problem is who needs to go up and open the door to get the food, because it's really a lot of work to walk to the door. And the introduction of the snack culture, where people feel like they always need to be grazing and snacking on something, and not to have a structured time for eating. There is less physical activity for sure from the day-to-day life, as well as in the work environment. And there is a lot of disturbance in sleep, and we definitely see this in our children and adolescents in this region, where they tend to stay up all night and sleep through the day, especially during school holidays. The genetic component of obesity, there is definitely a genetic predisposition, because you can see also a familial pattern. Most of this genetic is polygenic due to combined effect of many genes, and there's a lot of research trying to map these genetic variations that predispose to obesity. Monogenic conditions that result from specific mutations, they are relatively rare, but they are associated with severe obesity at a very early age of life. And there is the epigenetic effects of various types. So we go through programming in our life, where if our body gets used to doing things in a certain way at a very early stage, it gets programmed in that direction. And obesity does tend to track. So those who become obese at a very young age, most of the time they continue to become obese as older children as well as adults. So what about medical causes of obesity or genetic causes of obesity? There are multiple syndromes that are well known to be associated with obesity. So one of the simple ways to divide is to divide them into obese children with developmental delay or without developmental delay. Those with developmental delay can be things like Prader-Willi syndrome, Prader-Willi syndrome, as well as Albright hereditary osteodystrophy. Those who are not associated with developmental delay mostly are the severe monogenic types of obesity that actually manifest during infancy. The first group where those with leptin deficiency were identified and published, then leptin receptor mutations. After that, mutations were found in the rest of the pathway. Leptin works through stimulation of pro-opiomelanocortin, in which produces melanocyte stimulating hormone. Melanocyte stimulating hormone will do its effect through the melanocortin 4 receptor. The effect of all of this pathway is to suppress appetite and to decrease satiety. So mutations along this pathway will remove the satiety feeling and cause excessive hunger and food seeking. So obesity is associated with so many complications. You cannot think of anybody's system that will not be affected by it. So just to mention briefly, dermatological like acanthosis nigricans, hirsutism, and intertrigo. I have also seen some patients who get major problems with skin infections due to skin hygiene problems and unable to take care of themselves very well. So one of my patients used to get recurrent cellulitis. She actually had a very severe form of obesity that improved only after bariatric surgery. Endocrine complications, polycystic ovary syndrome, type 2 diabetes, prediabetes, and dysglycemia. Gastrointestinal is very important, and it's very common, non-alcoholic fatty liver disease and steatohepatitis. Neurological, like pseudotumor cerebri, orthopedics, osteoarthritis, and Pound's disease. Psychological, depression, anxiety, teasing, and bullying. Nephro, like FSGS, cardiovascular, dyslipidemia, hypertension, and cardiac disease. And also very important, obstructive sleep apnea, to screen for it, because many of the obese children who come to clinic suffer from significant sleep apnea. So when we see these children, we have to be selective of investigations that we do. Very often we feel obligated to look for an underlying cause, and underlying cause is actually very rare in obesity. Most of the cases are exogenous obesity. Yes, it is likely that most of these patients have an underlying genetic abnormality that is predisposing them to obesity, but most of the time this is polygenic and will not be identified by any testing. Endocrine causes of obesity, Cushing syndrome is really rare and will come with full manifestations, so there is no need to screen for it. And there is also no need to screen for hypothyroidism unless the patient has specific signs and symptoms to think about that. In addition, many children with obesity, they have mild elevation in TSH because of their obesity and not the other way around. So if you find subclinical hypothyroidism, it doesn't mean that it's abnormal or it's the cause of the obesity. Children with and adolescents with a BMI above 85th percentile need to be evaluated for potential complications and comorbidities. Genetic testing should be considered in severe obesity occurring at a very young age, certainly before 5 years of age. So the guidelines from the Endocrine Society outline all of the screening that needs to be done for these patients. The main systems to look at is the blood glucose, to look for prediabetes and diabetes, the lipid profile, the liver, non-alcoholic fatty liver disease to be checked by ALT, with some guidelines also suggest doing an ultrasound. Clinically, to screen for hypertension, so blood pressure should always be a routine part of the measurement. PCOS, psychiatric complications, and sleep apnea. So management of obesity is about improving health and well-being, and not just about the weight and kilograms. This is why it is important to discuss with the patient that our goal is not going to be an immediate rapid drop in the weight, because very often this will fail. So trying to improve the overall health of the patient and then try to gradually work on the weight and the BMI. The best BMI for the child may never be the ideal BMI. So even if they have significant improvement, they may not reach the ideal, and that should still be considered a good achievement and a good improvement for the patient. Success can be different for different children. We should try to work with them and not against them, and not to have a blame or provoke guilt feeling, and to try and stimulate and motivate them to have the change on their own, rather than feel that something is being implemented on them. The management of obesity is multidisciplinary management that needs to focus on all aspects of the child or adolescent life, including the behavioral changes and emotional problems, psychological, lifestyle, and dietary habits. The interventions should be family-based intervention, and not to be isolating the child as the target of the intervention. In some cases, now we will discuss the use of medications, and in some of the very severe cases, bariatric surgery becomes an option. So exercise does not, in most cases, does not lead to weight loss or significant weight loss. However, despite that, there are many benefits from exercise even without the weight loss. This includes a decrease in triglycerides, improvement in blood pressure, decrease in fasting glucose, decrease in body fat, decrease in insulin levels, as well as improvement in fasting insulin resistance. When this meta-analysis looked at the effect of physical exercise on the obesity, it's really noticed that there is no much benefit from a weight or a BMI point of view, but there are many benefits as mentioned earlier. When combining exercise with interventions, or dietary interventions, there is some improvement, but the improvement is really modest and not huge. When combining all of the above with behavioral therapy, the improvement seems to be a little bit better. However, managing obesity has always been one of the really difficult and frustrating things for physicians, because you invest a lot of resources in this, and the results are not really huge as far as improvement. And this means that this is a condition that you cannot just manage in the clinic. It needs to be managed at the society level, at the level of the laws and regulations, at the level of prevention from a very young age, at the level of education, school, at home. There needs to be a complete mindset of prevention from a very early age, because once they are obese, then interventions don't really work. Regarding medications, this is a brief summary of all medications discussed for childhood obesity. Orlistat is approved for children above 12 years of age. However, my personal experience is I have never started a patient and the patient desired to continue on it. So all of the patients I started stopped it within a few weeks to a few months maximum, because the side effects were not easily tolerated. Although in a clinical trial setting it was effective in improving weight in adolescents. Metformin is not a treatment for obesity, it's a treatment for type 2 diabetes, and studies have actually failed to show any significant improvement in weight as a group with metformin. Phentermine is usually listed among medications used in pediatrics, but the pediatric cutoff in our region is 15 or 16 years, so we don't really have much experience with this treatment. Topiramate for seizures can be associated with weight loss, but it's not indicated for that purpose. Sitmelanotide is now a treatment. It activates the MC4 receptor. So it's a treatment for patients with leptin resistance as well as deficiency in POMC and PCSK1. So this is a treatment for specific monogenic types of obesity that starts at an early life. Liraglutide has been licensed recently, initially for treatment of type 2 diabetes in children above 10 years of age, and then more recently for treatment of obesity in adolescents between 12 to 18 years of age. And this trial for liraglutide showed significant improvement in BMI SDS score during a 56 period of treatment. After 56 weeks, the treatment was stopped, and those who were receiving the liraglutide had a major weight gain when the treatment was stopped. There was also some weight gain in the placebo group. When we look at all of the patients who received liraglutide, we noticed that the majority had weight loss, even though there is a small group who did not benefit and had even weight gain. But 43% of the patients dropped more than 5% their BMI, and 26% of the patients dropped their BMI by more than 10%. Bariatric surgery can be an option in very severe obesity with a BMI more than 40 kg per meter square or more than 35 with comorbidities. It is preferable that children complete their puberty before they go through bariatric surgery. The patients need to put through a comprehensive program where they receive psychological counseling and support, and an attempt to try and help them lose weight with behavioral changes and lifestyle changes. So bariatric surgery becomes a last resort if all of this has failed. So in conclusion, obesity management is about improving the general well-being and not just the weight. Lifestyle changes over a long term are more important than just the weight loss by itself. Biological, behavioral, and environmental factors all conspire to resist the weight loss and promote regain, and therefore require weight maintenance specific counseling. The structured nature of the recommendations about specific concept, flexibility, but with clear limitations, may make families more aware of their food choices. Consider monogenic causes of obesity if the age is under 5 years of age, and new generation drugs now are holding some promise in improvement of obesity in children. I want to acknowledge Dr. Nadeem Abdullah, who is a consultant endocrinologist in our center at SKMC in Abu Dhabi. He is leading the pediatric obesity program in our clinic in a multidisciplinary team. He also was kind enough to share many of his slides with me, which helped me in preparing this presentation.